Hello, everyone. Thank you very much for joining us today for this webinar on learning from rapid data to inform policy on COVID-19 in Sierra Leone, Côte d'Ivoire, and Burkina Faso. My name is Fatou Conte. I am the Research and Policy Associate at IPA Sierra Leone, and I'll be moderating today's discussion. I want to let everyone know two things. First, there will be time for a question and answer at the end of the session. So at any time, you can send your questions through the question and answer box at the bottom of the screen, and we will answer as many of your questions as we can at the end. Second, the webinar will be recorded and will be made available after the session. Today's panelists include Andres Ulzinga, Country Director, Innovations for Poverty Action, Francophone West Africa, formerly Sierra Leone and Liberia. Dr. Shana Warren, Research Scientist, Path to Scale, IPA. Dr. Abby Clare, Senior Research Manager, Development Media International. And Mr. Sunday Sina, the Professional Head of the Ministry of Gender and Children's Affairs, Sierra Leone, completes our panel and we interact on IPA's COVID-19 data and its relevance to policymakers. As background for the Recover survey, at IPA, we do rigorous research to figure out what actually works to ensure that evidence is used to improve the way development corporations' finances are spent. IPA works across sectors, from education to financial inclusion and peace and recovery. More than 850 evaluations have been conducted around the world, mostly focusing on the 22 countries where we have a long-term local presence. We don't do any of this alone. We work in close partnership with hundreds of the best researchers from around the world, as well as with partners that are implementing programs and co-creating these with policymakers themselves. For further information on IPA's work, on the screen are links to resources on the IPA website where you can access information on the rapid response survey to answer critical policy questions in around 10 countries, a global hub that centralizes research and policy lessons in over 100 projects. And lastly, you can access information on advising governments on evidence-based approaches. Let us now have a more detailed look at what IPA results show for our Recover survey in Sierra Leone. Andres, over to you, please.
Thank you so much, Fatu, much appreciated. Welcome everyone from my end as well. I want to give you a few overview data points from the Sierra Leone survey that was conducted. And let me start with a few information about this survey and how we went about it. Initially, we had a random digital dialing exercise. As you can see here, the sample was nationally representative. And the second round was a panel survey, which means that we asked the same people, the same 1,300 people we called again for the second round. So that is the basis of the two survey rounds that we did first in May at the onset of the pandemic and the restrictions. And then secondly, half a year about later, when some restrictions were lifted. The general profile of our respondent, you can see here on the right-hand side of the slide. It's not surprisingly fairly young, given the young population and the median age in Sierra Leone. So from that side, it fits very much into the national image. But as you can see also here, there's a small bias towards a more urban population, as you can see from the other data points from the demographic profile. Let me give you an overview of the timeline where it fits, where our survey rounds fit in. So here you see that the first round was, as stated, fairly early on in the pandemic, and the second round was about 5 to 6 months later. Why this is crucial? We think that these are actually milestones when it comes to specific restrictions, and you can see that here, this is important to measure the perceptions, but also socioeconomic trends. As for the second round, for instance, it just occurred when schools were reopened. For continuity and consistency, to understand the medium-term impact, it would be important to have more data as we go into a different phase of the pandemic now, with first vaccines arriving in the country a few weeks back. I will leave that to the discussion later on. For now, I will focus on key takeaways from 5 different sections. They are health, food and financial resilience, education, employment, and of course, family relationships, given that we have our policy discussion today joining from the Ministry of Gender and Children Affairs. Let me start with health. In this first graph, you will note quite an interesting insight. In our first webinar after the first round, the Deputy Minister, Mara Cologne, noted that it is quite an important number for our country. So Sierra Leone doesn't have a very strong infrastructure when it comes to accessing, supporting, and dealing with mental health symptoms. But now that we see this number, it's quite important to think about what policy responses we should put in place. So you can see here that in the first round, so early on in the pandemic, respondents said about 1 out of 10 said that they themselves or someone in their household developed mental health symptoms, whereas now 6 months later in October, this number has more than doubled and was at 1 in 4 respondents. So with the socioeconomic, but also socio-emotional toll that COVID had, I think it's important to look at a more multidimensional policy response beyond physical health and think about what other components we need to address, politically speaking. In the next slide, there are 2 graphs, and I want to continue with risk perception and information about COVID-19 and so on. So on the first slide, on the first graph on the left hand, you can see that a larger share of respondents feel that they are at risk of contracting COVID-19. So that's interesting to note that between the rounds, this number has actually increased, despite or due to more increased outreach, information campaigns, but also support provided to populations. Second, on the next graph, you see that a larger share of non-poor respondents receive information from about COVID-19 from TV, while most stick to radio and social media as primary sources. Across both rounds, the majority of respondents, 72 and 78% respectively, consider the government's response to be appropriate. Also, more female respondents in round 2 share this opinion. The last note on health is on the next slide. You can see here that the majority of respondents would take the vaccine because of self-protection, followed by family protection. But this is quite an interesting data point, given that we are now comparing a bit the willingness to take vaccines to what we see currently in the rollout. So maybe we can think about incentive structures and other discussions to consider how vaccine take-up can increase. The other data point that we found quite stark is that from the people that would not take the vaccine, half of them are concerned about side effects. And I think it's also an important note for us to consider this and information campaigns that have linked to it. Here, we did not find statistically significant differences by gender or by geography in the likelihood of taking vaccines. The next section, I will focus a bit on some highlights of food security, but also financial resilience. And there are 4 overview data points on the next slide that you can see. And these are highlighting the economic effects of the pandemic. As stated before, the multidimensional policy response is key. And with these numbers, it's important to think about access to food, market prices, but also how they relate to income and related jobs of purchasing power. The last data point that you can see here on the slide, indicating that 63% of adults say that they had to limit portion sizes and portion frequency, is quite important, and that's why I want to spend a bit more time on it when we go to the next slide with 2 more graphs. You can see here that, at least from the data point, and again, bear in mind that the sample has a bit of a bias towards the urban centers, say that food insecurity worsened across the 2 rounds between May and October. Now, all the data points that you can see here, and I will give you a second to just absorb a bit the graphs, again, limited portion sizes, but also meal frequency. You can see why that is the case. And while some of the results are confirming a bit what we are anticipating, it is crucial to use evidence to underline our assumptions to respond in line with data insights. So bear this also in mind, given that some data points you might have guessed already, but this is important to still analyze. If we go to the next slide, we wanted to understand a bit more what it means about support systems and communities and families. And you see here that normally 1/3 of respondents say they receive assistance from family and friends when they're in economically difficult situations, but this has decreased. And what data or interpretation we can take from this is that also family support networks are feeling the impact at various entry points. So here, I think it's important to think about, of course, how the pandemic has affected not just one particular subset of the population, but also B, how we can think about different support structures linking from remittances to direct community support in the next policy response steps. In the last slide of this section, is a data point on nearly half of respondents facing severe difficulties in obtaining emergency funds. Where this number comes from, we can elaborate in questions if you have if you want to understand it better, but it's linked to the poverty probability indices and some other data points that we cross-compared to make sure that the 200,000 leones, which are about $20, make sense in the society. So for 48% of respondents, it would be impossible or very difficult to come up with this money within 1 month time. And certainly there's also a link to formality of labor markets and income in pandemics, as you can see on the right-hand side, when it comes to comparing how families would be able to come up with this money if they're in the informal employment sector, not employed, or in the formal sector. When spending a bit of time on education, I want to highlight, again, this is the case for all the different sections, but here especially we co-created the questions with a lot of policymakers and development partners that feedback before and especially after the first round, what kind of insights they would like to see. And for education, there was a lot of feedback on what we should add. So I think this is important to mention a few things. So let me guide you through the two graphs we can currently see. On the left side, the respondents are disaggregated in our 2 rounds. Round 1 speaks to the survey done in May, as said, and the other one 5 to 6 months later. On the right-hand side, you can see the difference between poor and non-poor respondents. Between rounds, while parents are less concerned about children falling behind in education, they're more concerned about their safety, food security, and other activities. Secondly, 1 in 5 poor respondents is concerned about their school-age children having enough to eat versus 1 in 10 of non-poor respondents. From a gender lens, we did not show the disaggregated data here, since men and women report similar concerns about their children during this pandemic. I think this is important to think a bit about what that means for schools and for retention and many educational policies, given that if concerns shift towards security, including food security, what does that mean for government and development partners alike, thinking about now or 6 months from now in a pandemic that is a bit more protracted? The next slide shows us that nearly all primary school students are using their own school books for educational continuity. And also we feature the National Life Skills Program. That is a radio program that many policymakers and development partners wanted to get data on. I want to draw your attention to the below schooling resources information. So while school books are crucial, the radio teaching programs were too. And the NLSP, the National Life Skills Program, is getting increasing interest and was used. So I think this is important for us to talk about future evidence needs or how to boost, adjust these programs during times when schools are open even. A bit more details now before ending the education slides on the NLSP. You can see here the frequency, but also the importance of the usage of it. And I think another data point that I want to leave you with is that more than half of respondents prefer that school children in their household listen to and learn from the program at home, even if it is continued during the school year. So perhaps also when schools are open, I think that might be interesting to look into assessing the impact of such a program more holistically and rigorously. I will delve quickly into the economic activity and employment section. Just a few highlights here. On the first slide, you can see that compared to June, employment increased slightly by October, but we're still not at a pre-COVID level. So these are also not, these are more confirming a few of our assumptions or anecdotal evidence that we've seen. I want to delve a bit more into detail on the next slide, into this exact graph. And as we can see there, among those working less since February, 4 in 10 report being unable to cope, and almost 1/4 have looked for a new job. And on the second graph, you see that among respondents whose labor supply fell since February, to cope, for instance, 1/4 of women have started a new business and more than 1 in 5 have taken on more domestic chores. So these are also quite important for our policy discussion later on. I will end this section briefly with the next slide, showing that just less than half of formally employed households were able to earn more or the same as the year before. Again, not surprising as it meets our assumptions, but it reiterates the need to look at analyzing, responding to, and focusing on COVID-19 as a multidimensional policy challenge, especially given that we understand a bit more the health necessities, I think, over this past year, but restrictions are changing and the economic impact needs to have perhaps another focus point. Given that we have our policy discussion today from the Ministry of Gender and Children Affairs, we also have a few data points on family relationships. And we could see that in our sample, a larger proportion of poor respondents report increased parent-child or inter-sibling conflicts. We can also see, however, that for a majority of inter-family conflict levels, they stayed the same. And it would be interesting to understand if this continues to be the case now with newest restrictions after our second round, and especially during the holiday season, where in Sierra Leone there was a second wave, as they quote, reverting back to curfew and having prolonged socioeconomic distress for families, and how it compares to now with lifting of restrictions and availability of vaccines, as well as the prioritization of people who have access to them. Lastly, we understand that during pandemics, curfews and lockdowns, cases of intimate partner violence went reportedly up. Our team has very cautiously bridged the topic, and the respondents were very open to answer. So we found here that there was concern of domestic violence, especially in relation to minors and romantic partners. And here again, I believe the question is quite crucial to look at what happens now and if there are changes. Before handing over to Mr. Sina, a few guiding questions to leave you with for a few seconds to think about policy implications for Sierra Leone. What longer term effects would this bear? What will the newest lifting of restrictions show? I want to just share that, as stated, poorer respondents are more likely than wealthier respondents to report having to sell off their assets to pay for food, healthcare, or other expenses since February 2020. And I guess we need to ask ourselves, are we adequately providing support to those most left behind? And on this last slide, we just provide a bit of evidence of other studies we've done and other activities that have shown us the insights into how we react and what policy implications there are. I'm not sure if you can see that slide, but there is interesting evidence also shown from sub-regional comparison data when we look at Côte d'Ivoire, where we understand that engaging learners by parents through text messages, for instance, can be extremely helpful for both educational performance and learning productivity, and especially in times of distance learning. I think this is important to think about what this means. And I will leave you with the last point and hand over to Mr. Sina, given that we've done a lot of studies in the gender space when it comes to pandemics' effect on empowerment, and I'm happy to share those, so please feel free to reach out to us, also during Ebola. And here I think it's crucial for us to think about what about SGBV cases, what about school dropouts, but also what is evidence of positive interventions that have worked, especially in pandemic contexts, when it comes to making sure that gender equity is there, that we can look into gender budgeting, but also into more transformative action. Thank you so much again, and over to you, Mr. Sina.
Yeah, thank you very much, Andy, for the presentation. Are you all getting me?
Yes, loud and clear.
Yeah, okay. Thank you very much for this presentation. And it's quite informative as we really look at it. It's evidence-based, a lot of indicators leading on to improving policy formulation and implementation. As you rightly said, like looking at the policy implications, I start from the latter part, the impact of the COVID on girls, especially when you look at in terms of sexual exploitation, early marriage, teenage pregnancy, and also school dropout. That was quite evident even in the time of Ebola. We saw that, and when children, their activities are limited, I mean, and when they are confined within places where there are no proper protection, care and protection, then it leads to some tears, and then it also sometimes leads into other homes, other places, lead to a way of survival. That is getting way to survive, living on own, those fortunate. So those things have actually shown us quite a lot. For me, when we look at a data of that, showing us such an indicator, then it gives us a signal that we need to improve on our community engagement, advocacy, and also monitoring. So I think this is where it is quite good for us. It's very good, especially in child protection. Policy formulation will heavily depend on data as evidence-based policy formulation. We cannot develop effective policies and strategies if we do not have evidence. And that is where we present case to people. And also that determines our level of implementation, management, how we manage situation. If from the data, we can look at the first case and look at our approach, and to the second stage, we'll see what level of improvement we've done. So you rightly mentioned just now we were looking at the issue of child sexual exploitation, which I even shared in terms of reference. There are a lot of perceptions around that we are seeing, but we cannot design an appropriate plan of action or policy if we do not have evidence to show. So for me, research and studies of this nature are very key. They guide us, our strategic approach and intervention into issues. But then you also talked about cases where best practices in some of these things were like, we also can say in the event of COVID and also like in Ebola, we saw a decrease in FGM, wherein we said associating, getting people together, living together, associating into societies. There was ban on that. And that leads to that long ban on it change the dynamics of people behavior. I mean, in terms of consent, gas, you stay for a long period, you're not getting yourself associated with that. So it leads to some form of neglecting itself and helped in reducing that. But then I also look at it in terms of messages, like you mentioned, SMS messages. We also look at it at some other level. It's good, but again, how do we control those messages when children do not have access to that? And if they cannot get exposed to pornographic things or whatever information, how do we? That leads to another level of how do we manage it? And I look at the presentation. For me, there are two keys here. The children aspect in terms of looking at conflict, how it's been happen in the home. When people are limited, confined to home, they don't move out to socialize or do some other activities. It definitely leads to conflict because men often spend lesser time at home. But when you confine them in the home and all of these siblings are there, it definitely leads to something very chaotic because so we've learned from there, and from there also we also step up what we talk about positive parenting, and that is where we are looking at how best can we manage some of those issues. But going back to the beginning of where you talked about mental health and psychosocial, this is something we also envisaged in Ebola time, and there was a strategy that was developed. Ebola mental health and psychosocial strategy was developed, and a bit of training was done. But what, for me, came out very strong is we need to partner up with key line ministries, especially health and social welfare and gender. We need to have a common strategy to work on, rather than working on a different approach in isolation. So I think that is where a challenge is in terms of dealing with mental health. So we need to work on a comprehensive strategy and a holistic framework to guide us in addressing those. You quite mentioned we do not have much of the capacity to handle that, and which is also a big of challenge in healthcare service and also psychosocial. So those, I think, for me, this research is actually quite key for us in terms of guiding us in moving forward. And when we recently look at also the aspect of generating the women empowerment and gender economic empowerment and equality policy that was done, there's a key focus on improving the lives of women. And we saw that in the COVID, how trade was stagnated, homes were also crippled. Women are, in most cases, are the ones that are the breadwinners in the home. Most good number of them, there are homes that are single parents, there are homes that women are there, but they are more actively involved in the informal sector, which is business, which is the main economic activity. And also going back to even agriculture, women are also quite huge there. So looking at bringing all of this information is also guides and how we can also work collectively to mainstream gender into all other approaches in terms of healthcare, agriculture, economic empowerment, and other sectors, education. When we're looking at the impact of all of this on girls, how do we improve that to bridge the gap and also work on the human capital development, which government is the focus on. And you also mentioned the aspect of access of food that can also lead to even the undermining the education efforts, strives being put in place to handle education retention in schools and the rest of it. So for me, this report is actually quite key, and it can give us a guide as a basis of working on policies and also improving on our network and collaboration with key stakeholders and how best to respond to issues. I hope I'll be able to respond favorably or presented a case here.
Thank you so very much, Mr. Sondesina, for your thoughts, your reflections, and even the questions you have and what you do in your ministry. We are happy to collaborate further beyond this webinar to see how data can support your programs. Thank you so very much. We will reach out to you beyond the webinar. So now we just want to usher the next presenter, Dr. Sheena Warren, will be presenting on the Recover Survey in Côte d'Ivoire and Burkina Faso.
Hello, good morning and good afternoon. I hope everyone can hear me. I'm going to be presenting data today from first the Recover Survey in Côte d'Ivoire, and then after that we will move on to Burkina Faso. So first, we ran 2 rounds of survey in Côte d'Ivoire as we did in Sierra Leone. The first round was in a tight window in June, and then the second one was in a similarly short window in October, just before the elections. We, unlike in Sierra Leone or Burkina Faso, we relied on an established sample from the integrated regional survey on employment and in the informal sector. From this survey, we drew a random sample across the country. We reached approximately 1,000 of the approximately 1,300 respondents we had reached in the first round, in round 2. So just to sort of situate this survey across time, you can see that we ran this just before the presidential election, is the Recover Survey round 2. And we also ran a follow-up qualitative survey looking at some specific programs in the education sector in distance learning. So today I'm going to be presenting from 4 key sectors. First, some questions on health and COVID mitigation, then on food and financial resilience, education, and finally employment. So we'll quickly go through those, mindful of time. So first, speaking of health and COVID mitigation, Can we advance? Thank you. So what we find is that risk perceptions and fear of COVID-19 were mostly consistent across the two rounds. For those who did not feel at risk of COVID, about 3/4 cite that it's because they follow protective measures. Although 61% suggests that it is because nobody is really at risk for COVID. So encouragingly, we're seeing that the belief that they're protected is rooted, in fact. So nobody feels at risk for COVID, but so 60% say that they're not at risk for COVID, sorry. But this is because 3/4 of them are following protective measures. Okay, this is not because people don't think the disease is real. This is really important as we move forward. As we've recently seen in South Asia, there are spikes that can come up later on in the epidemic. Next. Okay. Following up on this point, we find that 77% of respondents agree that they would take the COVID-19 vaccine. And we don't find a lot of variation across poor versus non-poor households. This is really encouraging for vaccination campaigns, but I would caution that ease of access and availability are, of course, still concerns. Furthermore, we can see among reasons why people would take the vaccine that the vast majority of respondents, the main answer is self-protection followed by family protection. So as we think about messaging, we should be highlighting personal health rather than sort of civic duty or safeguarding the community. Next. We also find that 1/3 of respondents believe that doctors and other health staff are their most trusted source for vaccine information. This is extremely important as we look towards communications to encourage uptake of vaccines as they become more available. Health workers will be the key levers in vaccine communication. And we see very little variation across poor and non-poor households, as you can see in the graph on the right. So now I'm going to turn to food security and financial security and resilience. So first, we see that the economic fallout from COVID-19 has continued to affect respondents' ability to access food. We have about 1/4 of respondents reporting shortages in the markets that prevent them from buying the goods that they're looking for. Over half are reporting drops in income that impact their ability to access food. And almost 1/3 are indicating that their children's diets are less healthy. This is particularly concerning given the closure of school feeding programs that had occurred over last year. Now we're going to dive a little bit deeper into these challenges. Okay. So first, we see that there are some improvements from the round 1 survey in June to our follow-up in October. But the situation is still concerning. The proportion of respondents who cite specific barriers in accessing sufficient amounts of food is decreasing, but we still see almost 1/3 indicating that there are shortages in markets, and nearly half indicating that the price of food is too high. Some of this is, of course, a general situation, but we should note that COVID has had a serious impact here. We also still see some adults and children going hungry every day during the last weeks of October. So this is this final category on these two graphs, on the left for adults and on the right for people under 18, where we see 13% of adults and 9% of children having gone without food by limiting portion size or skipping meals within the past week. Now we're going to turn to education. We're going to look at some findings about efforts to mitigate learning loss during school closures. So first, we've asked respondents, what children in their household are doing during school closures. So students are most frequently using textbooks to continue their education at home. A slightly higher proportion of poorer students are using textbooks to do so. And this, of course, makes sense since poorer households are less likely to have access to mobile remote learning technologies. So we see that despite a lot of new innovations in educational technology, the vast majority of students are still relying on textbooks, even though there have been efforts to produce SMS learning, internet programs, radio, and television. We also dive more deeply into a television program, a television or radio program, Ma Radio, Mon École avec Tonton Jojo. This radio program was broadcast in some parts of the country. It was not a nationwide program. Among those households that had engaged with the education of their children, 31% of respondents have at least heard of the program, which is quite encouraging. At the same time, more than half of those have never listened to it and don't have enough information to assess the program. We would suggest that this program merits further research and development to establish what can be done. Can this continue during the school year? And we did some of that in a separate qualitative study. I'll now turn to economic activity and employment in Côte d'Ivoire during the crisis. So first, we see that more than 3/4 of heads of households worked in the week the survey was administered. And of those, nearly half are earning less or maintaining the same hours. So there has been a huge loss across the board in employment, and we see very minimal variation between poor and non-poor households. In fact, the economic crisis has touched Ivorians across the board. We also note that there's limited variation in return to work by economic sector of activity, though only 3/4 are still with the same employer. Most individuals are still struggling with employment. In order to keep our discussion today moving forward and have time for questions, I am now going to turn to our work in Burkina Faso. First of all, the second round of the survey occurred between October 15th and December 4th. This seems like a longer period, but in fact, some of these were simply individuals that asked us to follow up with them, and we had to wait to post-election time to do so. This was a random digit dialing survey, similar to what we had in Sierra Leone rather than Côte d'Ivoire. And again, we reached about 1,000 respondents of the approximately 1,300 in the first round of the survey. Looking at the survey and policy timeline, we again note in both of the Francophone West African countries that the general elections in 2021 occurred in close proximity to our survey. And this was part of, as we described, the reason for delay. We paused the survey just before the election and gave a little time afterwards to catch up, given that respondents' interests were elsewhere. In this survey, we're going to cover 5 key sections: health, food and financial resilience, education, employment, and in addition, we do discussion of family planning. We'll go quickly through each of them, starting with health. So the ongoing COVID crisis has impacted beliefs about the disease as more information has been learned. So at our first round of the survey, we were still establishing how the disease could transmit, what the best mitigation efforts were. For those who do not, so first of all, we found that about 60% believed that no one was at risk of contracting COVID in the first round, but now we are down to 46%. So more and more people believe that COVID-19 is a real risk. Encouragingly, we see that this belief is rooted in following preventive measures, not a lack of belief that COVID is real. And we see this even higher in Burkina Faso than we did in Côte d'Ivoire. When it comes to vaccination, we asked a short series of questions before any vaccines were available. Remember, this survey occurred in October and November, just as phase 3 clinical trials assessing efficacy as well as safety were just being made public. The majority of respondents would take the vaccine, 69%, so over 2/3. And the majority are doing so, they say, out of interest in self-protection, followed by family protection. This is significant because it again suggests messaging strategies. Of the 31% who would not take the vaccine, almost half cite worries about its side effects. This suggests that these are a convincible group when it comes to vaccination. If your concern is side effects, given delays in vaccine access in countries like Burkina Faso, there will be more evidence than there has been in some of the early adopters of vaccination By the time vaccines are widely available in Burkina Faso, millions and millions will have been vaccinated worldwide and more information will be available. Half of all respondents indicate that they really want they trust in their healthcare workers to provide them advice on this. And this again suggests messaging strategies. We did not find any statistically significant differences by gender or geography in the likelihood of taking the vaccine. I'll now move on to food security and financial resilience. First, as in Côte d'Ivoire, we see that various aspects of food insecurity affect about 1 in 4 respondents. It is important to note that in addition to the COVID crisis, there has been an ongoing security crisis in some parts of Burkina Faso that has also impeded access to markets during this time. So we see much lower shares impacted in our Burkina Faso sample than in Côte d'Ivoire, where we see approximately 1 in 5 Burkinabe reporting shortages in the markets they were buying from in November, and about a quarter suggesting that it is drops in income that have prevented them from buying food. However, more concerningly, 60% of respondents indicated that children in their households have experienced a less healthy diet during this crisis. I will note here that schools in Burkina Faso remained closed for an extended period, and again, this affects access to the World Food Programme's school feeding programs. We'll now dive a bit deeper into these challenges. So there have been decreases on the order of 20 to 25 percentage points in respondents' ability to buy their usual amounts of food from markets between rounds. So the first survey round is shown in green and the second in blue. This is very hopeful. We find that high food prices and reduced incomes are barriers for a higher proportion of poor respondents compared to non-poor respondents, as we would have anticipated. We don't find statistically significant differences between urban and rural respondents. And we don't find statistically significant differences between households with and without school-aged children to buy their usual amounts of food from markets because of shortages, high food prices, or reduced incomes. While 20% of respondents indicate that they have family and friends that can help in times of need, nearly half report receiving less than usual support from that source. This is important since many individuals rely on extended family in times of crisis. We do not see statistically significant differences between the level of support that men or women have received compared to a typical six-month period, or between respondents with and without school-aged children or household members over 60. This is an across-the-board difference, and it reflects that the economic crisis is widespread. It is not just touching on the poor. Next. Almost a third of respondents indicate that their children used to eat at least 1 meal per day through a school feeding program before schools closed. And this is more true for poor and for rural respondents. Again, this suggests that poor and rural respondents are most likely to have been relying on school meal programs before the pandemic and to have suffered negative impacts on food security due to the pandemic. Next. Finally, as I mentioned, the security situation is of concern. In Burkina Faso, almost 1 in 10 respondents indicated that they felt it was not safe to travel to markets due to these security concerns. This was equally true of male and female and urban and rural respondents. This has also impacted the ability of respondents to sell their agricultural products. I'll now turn to education for a few minutes. So at the time of the survey in November, 3/4 of respondents preferred for primary and secondary level students to return to in-person schooling. And we found that during the extended closures, few students had been pulled into the labor sector. Okay, so students have not been pulled into labor and families want their children back in school. And as we see on these 3 graphs, the first one on the left is all respondents, and then the second 2 we subdivide between rural and urban. We find that even over time, there are no significant differences in what children are doing. The vast majority of children during the extended closures have not been pulled into the labor sector. If they're doing any work, Most were doing household chores. This is a hopeful sign that children will have returned effectively to education as schools reopened. I'll now turn to economic activity and employment for a few minutes. So our first headline finding here is that a majority of heads of household have been working within the past week, 81%. And a greater proportion of non-poor heads of household have been working in the past week, though this difference is not statistically significant between groups. Rural and urban heads of household and individual respondents report similar rates of working in the past week. Yet nearly 2/3 of respondents are themselves actively seeking new paid employment. As you can see in the sort of center line on the left-hand graph, which covers all respondents, and the right-hand graph where we subdivide into poor and non-poor households. Among those working in the last week, the proportion working fewer hours has decreased across rounds. Overall, we find that 76% of non-poor respondents are working compared to 63% of poor, and 78% of male respondents are working as compared to 54% of female respondents. We also observed a drop, as I show in these graphs, of 38 percentage points in those respondents working fewer hours in November compared to the early months of the crisis. It does appear that the economic situation has improved in the second half of 2020. Across rounds, we find that a majority of respondents could obtain emergency financial sources. We cite 20,000 francs CFA in a month. So this statistic, Andreas had mentioned this earlier. What this is, it's a cross-national comparison asking individuals if in an emergency they would be able to obtain 1/20th of the GDP per capita in their country. Okay. So this is, in a crisis, could you raise that kind of money in a month? We find that a majority could do so, though more than 1 in 4 would find it fairly difficult. We do not see statistically significant differences between rural and urban respondents, which is not shown, but we do see larger differences between poor and non-poor households in the direction that we would anticipate, and between men and women also in the direction that we would anticipate. Men and wealthier, or at least non-poor households, are more likely to be able to obtain this money. This may be due to savings, it may be due to employment, and it is also likely attributable to the networks that they have to rely on in times of crisis. In Burkina Faso, as part of IPA's long-term partnership with DMI on family planning access and uptake interventions, we've included a short set of questions about access to healthcare and family planning during the COVID crisis, when many women were limited in their ability to go out and seek that care. So first, we learned that 1/3 of respondents are using contraceptives, but that many more plan to do so in the future. This is unchanged since the first round of data collection and suggests that there are women with access, but it may be that more would like that access. Second, we observed that about 10% of respondents indicate that it has become more difficult to access family planning since the onset of the crisis. And 3% of respondents indicate that girls under 18 in the household have gotten pregnant since the onset of the crisis. This 11% is a decrease from 18% in the June survey, suggesting that access to family planning has improved. I will note here that due to ongoing security concerns in Burkina Faso, that a large share of health clinics across the country have been closed for extended periods during the crisis. So this is not just that COVID has prevented people from going out, but that the health center closest to them may not be accessible at this time. I'm going to wrap things up so we have plenty of time for questions and think about what some policy takeaways might be. So first, I would note that many households are suffering from the economic impacts of COVID. We know that mobile money provides access when individuals can't reach a bank and is more rapid and cost effective. We know that cash transfer programs more broadly, including those using big data to identify recipients, can help mitigate the effects of a crisis. Food ration programs can act similarly, and we hope to see unmet needs being met, especially as we look to the reinstatement of school feeding programs to help to mitigate potential adverse impacts. I would also like to highlight vaccination uptake. As of now, and this is across all 3 countries in our study, intentions are high. But we asked these questions before the specific vaccines that will be or are available in these countries were already in the market. As new information on safety and effectiveness is available, it will be important to engage with communities about the vaccines, how to obtain them, how safe they are. And we note that our survey provides data in all 3 countries that indicate high levels of trust in health workers. These health workers should be engaged in communication. So there have been a lot of discussions publicly about having role models and celebrities, but in the end, most people are interested in hearing from the health workers that they have come to trust. I would also suggest that we could rely on some of the learnings from countries like Sierra Leone and Liberia in the case post-Ebola of how do you build trust in the health sector and then leverage that trust to increase vaccination in this new pandemic crisis. I've gone very quickly, so I will leave this here and I'm happy to answer additional questions. Thanks everyone for your attention.
Thank you very much, Dr. Sheena Warren, for a very informative presentation. So I will now like to welcome Abby Claire, the Research Manager for Development Media International, to make a statement and share a reflection on the Burkina Faso and Côte d'Ivoire recovery data. You're welcome.
Thank you, Fatou, and thanks, Shana, for your presentation. Yep, so I'm a Senior Research Manager at Development Media International. And for anyone that isn't familiar with our work, basically we specialise in doing mass media campaigns, mostly on radio. And we've been working in Burkina for over 10 years now, very often in close collaboration with IPA. So these recover surveys have been really useful for us because we have 2 major ongoing radio campaigns. One is on treatment seeking. So we message on encouraging people to seek treatment early for diarrhea, pneumonia and malaria in under 5s. And our second big campaign is on family planning, so encouraging increased use of modern contraceptives. So for both of those campaigns, we actually broadcast 10 times a day, every day, 365 days a year on those topics. So it's important for us to keep up to date with what's going on the ground. So the recover surveys have been useful because, for example, for our treatment seeking campaign, it's really interesting that this survey has found that the healthcare access is actually quite high and has been around 92% across both of the surveys. What is interesting is that for the people that aren't accessing care, in the second survey, the cost of care was quite a large barrier. So we're quite interested to understand why that is the case. It was a big change between the first round and the second round. Healthcare, I think, is free at point of access. So we're just kind of curious where those results have come from. For family planning, it's good to see that the rates have stayed quite stable. And it's also great to see that although there seem to be quite high problems with access in the first round, in the second round, those access issues seem to be reducing. So we're down to kind of 11% of people saying that it was difficult to access family planning. Again, it would be interesting to know why, if we could ever dig down more deeply into those results. That would be really helpful for us. And then COVID trends is obviously a really hot topic for DMI. We are campaigning on, well, we have campaigned on COVID in Burkina Faso from the perspective of encouraging mask wearing and social distancing and all of those preventative measures. So we have been messaging on that for about 8 months, I think. And in other countries, we're starting to do vaccination campaigns. So in Malawi, we have started doing campaigns on encouraging people and health workers and the elderly in particular to go and get vaccinated. So it was fascinating actually to see in Burkina Faso that 69% of people say they would take the vaccine. I was really surprised. So yeah, very promising results. And I mean, overall, this survey tells me that I think we can keep telling people to go to the health centres. I know security has been an issue, but interestingly, this survey hasn't necessarily picked that up. So in general, it seems like the situation is quite good. We can keep messaging on family planning without too many worries that people won't be able to access it. And there are positive signs for future COVID campaigns as well. So thanks to IPA for all their work on this.
Thank you very much, Abby, for sharing these pertinent perceptions, interesting questions and comments. I believe this is exactly what we will need to have a fruitful discussion at the end of this webinar to move us towards evidence-based policy debates and solution finding exercise. We hope to talk more after this webinar. Thank you so very much for sharing your thoughts. So now I think we are at the phase of question and answer. I just see one question in the answer box. Please feel free to send in your questions and the presenters will answer them. So I think the question we have here has already been answered, but maybe more light can be shed on it. It's a very important and interesting work. However, would you please shed light on the number and characteristics on the COVID-19 vaccine take-up population? So I don't know whether Andres or Shena, if you want to shed more light on this question.
I can certainly speak about this in terms of, intentions. Remember, these surveys were deployed prior to vaccines being available, and then perhaps Andreas can follow up a bit. So in terms of the characteristics of who would take up vaccines, we, as you saw in these presentations, we had very high levels of intention to vaccinate, over 75% in all three of the countries we presented data on today. We do not find significant differences by gender, although the estimates for women tend to be lower than for men. This could reflect increased concerns about a vaccine, but it could also reflect the lower likelihood that women are working outside the home and are as exposed as men might be. It may, in fact, reflect a very nuanced understanding of how COVID is transmitted. In terms of educational attainment, we find that in, for example, Burkina Faso, we have actually less educated respondents. Those with less than a secondary education are more likely to say that they would take up the vaccine than those with more education. This was at the time of the survey. This may reflect a broad confidence in vaccines rather than specifics of the vaccines. It may reflect that the most educated respondents were trying to follow what was at the time a very unclear bit of information about how effective different vaccines were. Remember that throughout the month of November, the 4 vaccines that are most prevalent globally today were all reporting their stage 3 clinical trial results for the first time. In Sierra Leone, we do not see a significant difference across education in take-up of vaccines. Similarly, despite what we find in countries like the United States, where the older a respondent is, the more likely they are to take up the vaccine, we do not find significant differences across age groups in Sierra Leone or Burkina Faso or Côte d'Ivoire. There is sort of an across-the-board take-up. This is a really hopeful sign. As vaccines become more broadly available, we will of course see if intent lines up with action. But we've also found in these surveys that across the board in all of the countries we surveyed, and in many more through some collaborative partnerships with the IGC, that in general, within sub-Saharan Africa, respondents have relatively high trust in the health sector as their go-to source for advice on vaccination. So as we think about campaigns to roll out vaccines to the broader public, we should be thinking in those terms. I will turn it over to others rather than talk too much.
Thank you very much. I think we are having more questions coming in. Mr. Sina, this is going to you. This data has been developed with the express hope of driving more informed decision-making among organizations and policymakers. With that, what initial takeaways do you have from the data presented by the Recover surveys? And what can organizations like IPA do in order to about data and evidence? Mr. Sina, this is for you. Like, what will your ministry do? What are the key takeaways you will have from the data presented today? Mr. Sina, please.
Yeah, as I earlier mentioned, the data presented has shown us key indicators where we can also point policy direction, especially in terms of gender mainstreaming and responding to more child protection issues, challenges. It's shown in COVID, what are the issues, what risk children and women do face. So with that as clearly shown to us, backed with other evidence. And for me, I think the RICO survey, it will be more helpful if we can also work in partnership with IPA to do a more thorough research and surveys into issues that guide in policy, evidence-based policy studies to guide us in policy formulation and development. That is my take. The evidence is shown our guide, as we also talk on the issues of when we talk about the family, the parenting pattern, what happens in a normal situation, emergency situation. It has clearly shown to us. So I think it's very key. We need to work on these. I think it will also be good to have a kind of forum where the key stakeholders, particularly when we talk about education and what, so they come together and we go through this presentation as well, share the information. I think that will help quite a lot.
Thank you. And there's another question here. What about further regional and inter-regional COVID-19 trends? I think this is going to you, Shena. You want to respond to this? Talking about trends of COVID-19.
So my expertise is certainly not in the spread of the disease on the medical side, but regionally within sub-Saharan Africa and within West Africa, we do see broadly that respondents in our surveys and in other surveys are interested in getting vaccinated. And we can look back to even broad surveys before COVID. There is relatively high trust in the safety and efficacy of vaccines in the region. And we can look to lessons, for example, from the Ebola crisis of how you strengthen health systems and build faith that the health system is there and safe for you as we look to bring respondents back to the health centers and get people in, not just for COVID vaccinations, but indeed for childhood vaccinations across the board. In terms of disease spread more broadly, we've recently seen a very large and disturbing uptake in South Asia that has resulted and continues to result in serious threats to morbidity, mortality, and the integrity of the health system. So this does remind us that even when it seems that COVID has passed you by in the most severe form for a while, it can reemerge, as has happened with repeated waves in Europe, in the Americas, and now in South Asia. I believe Andreas wanted to add some comments as well, so I'll leave this to him.
Thanks so much. Sure, gladly. And I think at IPA, with also Shayna's work, we basically show an example to make sure that we have some more comparative data points, which is what we tried with this webinar as well. So when it comes to having access not only to national data sets, but also sub-regional, this is key. So I think moving forward, we can certainly look into how we can propel this evidence generation and review to the next level. Before moving on, I quickly wanted to react also to Vasiki's question, since I think it's very important to think about what the vaccine uptake is telling us now and what we can maybe anticipate also with the data that we've shared from Sierra Leone and from as well Côte d'Ivoire and Burkina about it. So I think what we saw is that there's a lot of willingness to take the vaccine, but it doesn't reflect adequately in right now the take-up, at least from the experiences we've seen. So number one, anecdotally, the uptake of disinformation campaigns through social media platforms such as WhatsApp, when it comes to fertility loss and other statements made when it comes to the vaccine, is something that is quite worrying, and where more investigation is ongoing from us, but also where maybe more data collection is needed. When it comes to the specific numbers, the only ones that I can share with you that I have is that from the initially 96,000 vaccine doses that came in through Sierra Leone early March through the COVAX facility, of I think in total over 500,000, plus about 200,000 from development partners. So far, only about 60,000 have been administered of those doses. So I think, given thinking about the population of Sierra Leone, which is about 8 million, this number is very low, both in terms of vaccine availability, but also in terms of take-up even more so. So I think what would be immensely helpful is to make sure that we have not only evidence and data showing what kind of vaccines are being utilized, what kind of take-up we see, but also disaggregate here. And as Mr. Sine said, disaggregated by genders, but also making sure that we understand which subpopulation groups are having access, are willing to access, and where the disinformation campaigns are yielding more negative perceptions, let's say. So what is the fertile ground that we can touch, but also what interventions make sense for us to increase uptake and make sure that the doses, at least the limited amount when it comes to vaccine equity campaigns that we can see, are being utilized for the population. Thanks a lot.
Very much, Andres. I see another question here relating to radio spots. I think this is for you, Abby. How long are the radio spots? Abby, please.
Yeah, hi. Yep, so our radio spots are generally 60 seconds long. So we broadcast a 60-second spot 10 times a day, every day.
And Abby, I had a quick question as well on the radio spots. Do they vary in the content, or just
yeah,
like
sure, sorry, I could give you more information. Yeah, so often generally we tend to play the same spot for a week, so that we just make sure that everybody hears the same spot, and then we rotate the spots. And our rule of thumb is that they are drama based, so they'll always be kind of around the life experiences of rural villages, if we're talking about Burkina Faso. And yeah, we're trying to make them interesting, funny, rather than kind of dry and, you must do this, you must do that, etc.
Mm-hmm. Great, that's wonderful, thank you. And I had a question as well, Fatou, for Mr. Sina, regarding the mental health model that he had mentioned in the Ebola crisis, and just if you could expand a little more on what that model entails, and again, how these learnings can inform that for this pandemic.
Yeah, the mental health psychosocial strategy that basically that was put in place, it was after the first aid psychosocial to the Ebola emergency. So the mental health strategy that was developed was basically defined the framework into which mental health services could be delivered with institutions in terms of looking at community-based organizations and NGOs, what services they can provide. It's actually defined a framework within which mental health and psychosocial can be delivered. services to survivors or victims of Ebola. So this is something I think I was just saying we need to also look at that and see how we work on a broader mental health and psychosocial support that fits into both the health sector and the social welfare, education, and also gender and children.
Thank you very much, Mr. Sondesina. And I think another question we have, what incentives could we utilize to increase uptake? I think this again should go to Shena.
I'm happy to speak on this, sort of using evidence. We can think about evidence from other vaccine programs. In fact, we have at IPA just produced a brief. I believe I received an email about an hour ago. I think it's online now. Looking at lessons from early childhood vaccination campaigns and how we can apply them to uptake of COVID vaccines. So first, there's simply the question of ease of access. If you're asking someone to miss out on many hours of a paid workday, if you're asking people to cover long distances, these are challenges that make things more difficult. Furthermore, many of the vaccinations have 2 shots, most of the ones that are going to be distributed in all likelihood in West Africa. This means that individuals need to come for their first vaccine, and then they need to remember to come for their second one, but not either too early or too late. So we know from existing research that reminder interventions, phone interventions, can work to remind people to return for vaccines, as well as efforts even on the radio. Have you gotten your second shot? All of these public health reminders. We can also leverage trusted healthcare workers to tout the safety and efficacy of the vaccination when the time comes to advertise to the wider population. Of course, you don't want to go in too hard on getting people to come for vaccines at a time when, as Andreas pointed out, the number of vaccines available in the country pales in comparison to the population need. So this needs to be sort of an incremental strategy. I think I can also pass this to Andreas to speak about some data collection efforts during COVID times. I would like to first ask Abby if she could describe some of the COVID vaccine uptake efforts that development media is working on at the moment.
Sure. So we've only started in Malawi at the moment because they're one of the first countries to get shipments of COVAX vaccines, and similar to other countries have been experiencing problems with uptake. So we've just sent, I think, about 7 radio spots to the Ministry of Health. The request came directly from them, and it's mostly been around side effects. The Ministry of Health has done a lot of research on people's concerns. Some of our spots addressed side effects, some of them addressed some of the conspiracy theories that are floating around, which did make for some pretty good drama in some cases. So yeah, we'll see how they're received. We're planning to do some feedback testing on our spots maybe in a month or so's time. Just, have people heard them? Where have they heard them? What do they think of them? It's hard to evaluate that kind of campaign rigorously, but we'll do our best with qualitative focus groups and take it from there. I imagine there will be more to come as the vaccine programs roll out. So watch this space.
Thank you, Abby. We have a question. Are there any plans by IPA to conduct a similar study in Liberia? Maybe Andres, you want to answer, or anyone?
Sure, yeah, definitely. And also I would like to comment on a different question I see here on how we go about data collection in COVID times and if we always do phone service. I think that's fair. So let me quickly touch base on Liberia first. So generally, we were commissioned for certain countries to look into it, and Sierra Leone, Côte d'Ivoire, Burkina have been priority countries also when policymakers reached out to us and when we discussed with them. I think it's quite interesting and pertinent to continue data collection in the sub-region, also to make sure that we understand the nuances and the idiosyncrasies that are linked to specific policy responses and also government restrictions, and how those have maybe different socioeconomic tolls on populations. And why I'm saying this is because in Liberia, at least, we see that maybe restrictions have been quite different from the ones that the neighboring country Sierra Leone has shown, although there are oftentimes many similarities that are drawn between the countries. I think the impact might be quite differently registered there. So I cannot speak to it because I haven't seen evidence on that so far, but taking into account the caveat that we would start fairly late on in the pandemic and the restrictions, I still think it's a worthwhile exercise to continue assessing what evidence is useful and then also what can be deduced for policies to be more adequate and targeted for specific subpopulations. The second part was on data collection in the field. That's very fair. So what we're doing right now, we shift a bit at IPA depending on the country locality, of course, and on the specific government norms, but also on what is feasible, since health and safety, of course, of our team, but also of the communities we aim to serve is still our #1 priority. But still, in some instances, we are able to go back into field data collection. So it's not all done by phones, as this Recover survey might have given the impression. So I think in further rounds or in new activities that are linked to assessing a bit the COVID-19 socioeconomic impact, if that were to happen in Sierra Leone, at least for now, depending on the trends, of course, that could be possible, since we follow very strict guidelines on making sure that we are mitigating all effects that we could have, since we certainly do not want to be contributing and spreading the disease, but rather in making sure that we contribute to solution finding. Also, one important notion on what incentives work and what Shana just mentioned. So we do work in Sierra Leone very closely with one of our favorite principal investigators and Professor Anne Caring, and Fatou, you are also on the research team there. And here we have been looking for many years into what social incentives and social signals can do and cannot do when it comes to making sure that vaccine uptake is increasing, both in terms of timeliness and completion of vaccines. So certainly there are some deductions we can make for COVID, some maybe not as much, but this is quite interesting when we try to understand what incentives may be useful and what maybe we should certainly adjust for the different type of diseases and different immunization goals that there are. But this is a study, again, I'm happy to share the link with you or anyone else that is interested, to show a bit of the work that has been done, the evidence that has been generated by her and our teams. So that may be quite interesting, but that is only one aspect of what incentives could look like. Maybe, Mr. Sina, I would also like to direct this question to you a bit, if you allow, when it comes to government incentives and thinking about the gendered impact, or potentially also going towards gender budgeting, as mentioned before. What do you think is a good way for the Ministry of Gender and Children Affairs to make sure that also there are maybe less disinformation campaigns when it comes to fertility and other streams of communication that we see out there at the moment? So if you have any insights and want to share on how we can incentivize the Sierra Leonean population at large, and more specifically women, to make sure that the vaccines are being utilized, that would be quite insightful. Thank you.
Yeah, I think that's what you said, the vaccine to be more decentralized or what. I think we also just need to step up advocacy and sensitization on it, based on the perception some people have with regards the conspiracy theory or whatever myths they have around. I think they will not be able to, they are not fully informed or sensitized on the relevance or the significance of the vaccination. So I think that is what we also need to step up. But then it's just like we just said, is letting people get access to some of these study results, and then we discuss around that and sometimes have a roundtable discussion around some of these issues with the key stakeholders. I think for me, that would be very key.
Thank you, Mr. Sina-Sunday. So if there are any more questions, please send them in so the presenters can answer the questions. We are almost getting on to the time. Okay, so as a final wrap up, if you're interested in partnering with us or learning more, please reach out at contact@ipa-action.org. We thank the Bill and Melinda Gates Foundation, Northwestern University, the Jacobs Foundation, and other anonymous donors for their support of the Recover Initiative. Thanks everyone for joining the webinar today. For more about the Recover Initiative, visit our website. Feel free to send us further questions you have. And as mentioned, the webinar has been recorded and will be available after the session. A big thank you to you all, and thank you, as we say in Creole, from Sierra Leone. Thank you.
Thank you.
Thanks, everyone.